Thank you for joining today's NILE webinar. My name is Emily Ruzzini. I am the Events Director for Immunize Nevada, and I will be today's NILE webinar moderator. Before we get started, I'd like to review a couple of housekeeping items. First, in case of any communication breakdown, which we do not anticipate, we do want to let you know, just call right back in and log back on, and we will continue. Like I said, we do not anticipate any sort of communication breakdown. First, please locate the chat box in the bottom left corner of your screen. If you have any questions, type them in the chat box, and we will address those questions throughout the presentation and then again at the end of the presentation. Secondly, if you have requested nursing and pharmacy CEU continuing education credits for today's NILE webinar, please make sure you complete the survey in the post-webinar email that will be sent to you after the webinar today by the end of the day. And then CEUs will be emailed out within the next week. A little disclaimer, Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for the community partners to gain knowledge and immunization-related topics throughout non-branded and unbiased presentations. I would like to now turn the presentation over to Johan Bester. Johan is an academic bioethicist who previously worked as a physician in family medicine and emergency medicine. He teaches bioethics, epidemiology, and evidence-based medicine at UNLV School of Medicine in Las Vegas. Dr. Bester, I'm going to go ahead and turn it over to you now.
Thank you so much, and thank you everyone for joining us for a topic that I've been thinking about and working on for quite some time now. So if you're wondering about where I'm from South Africa originally, but I also spend a lot of time in Canada, and I've been in the US for a number of years now, but obviously the accent is still there. If you wonder about those letters behind my name, the MBCHB is in the Commonwealth, there's a variety of different medical degrees. So that is a South African medical degree. And then the PhD is in ethics. So the picture you see is of Edward Jenner and a depiction of his first inoculation, widely thought of as the father of vaccination with his discovery of smallpox vaccination. Now today, I want us to focus on a specific argument. Before we get to that though, I just need to disclose to you that I don't have any financial conflicts of interest, and any pictures you see in this presentation are in the public domain, so they're not mine. So I've come across in practice a specific way of thinking in highly vaccinated societies that you might have run across as well. I've also picked this up in the literature in what some people write. It goes like this. In a highly vaccinated society, the risk for getting measles is low because everybody's vaccinated against measles, so you won't get into contact with measles. So the benefit from measles vaccination is therefore low. Measles vaccination has risks, just like any medical intervention. There are small risks of adverse effects. And we should really do what is best for the child. So if you put all that together, some people would say non-vaccination is really best for the child. So that way the child is protected through herd immunity while not running vaccine risks. Now, if you think about this issue, you could see how this can be problematic just on first glance. If people think this way, they might think they really have an obligation not to get their child vaccinated, or if healthcare professionals think this way, they might think, well, it's really not that big a deal to talk about vaccines or so. Now today I'm going to sort of examine this argument and show you why it is not successful. So the first thing I'm going to do is just give us some background on measles and vaccination and some basic facts regarding measles vaccination. I'm going to talk a little bit about the ethical principles of how we make decisions for children in healthcare. And then I'm going to come back to this argument that we just looked at, and I'm going to show you why we should not be persuaded by this argument. I was also asked to just share the following. make some suggestions for policy, which I have written about, and giving you some tips on how to talk to parents about these concepts and these issues. And I'll do that at the end of the presentation. So the presentation I'm going to give you is based on ideas from my published work. There is the reference, and we will be posting this as a PDF afterwards if you're interested in the article itself. So let's get to measles and measles vaccine facts. Now the first thing we need to say is that measles is dangerous and highly infectious. It's been described as one of the most infectious illnesses known to man. If you put it into a susceptible population, more than 90% of those people will be infected, guaranteed. The reproduction rate is something like 17, which means every case of measles gives rise to 17 more cases of measles. Now, if you do the math, you can see how that snowballs. Measles is dependent on person-to-person transmission. There's no animal vectors. It doesn't exist in the environment. It purely exists in human-to-human transmission, but it's very successful in existing that way because it is so infectious. Now, if you get measles, you become sort of fevered, you have a rash, you're very ill with something like a severe flu for a couple of weeks, but that's not all of it. Measles can have really severe complications. Data from the United States, for example, show that about 30 to 40% of measles cases will have some sort of complication. And this includes things like diarrhea, otitis media, pneumonia, which is also the leading cause of measles-related death. It can cause seizures. It can cause a variety of serious brain infections, which all have dismal prognosis. It can cause death as well. Now, figures in the United States show that deaths are about 2 in 1,000 cases, but that is based on data from outbreaks in the past, say, 50, 60 years. If you go back a little bit, or if you look at countries where the healthcare access is not so good, or you have a lot of malnourished children, or vitamin A deficiency, the measles death rate can be as high as 25%, meaning 1 in 4 people can die. And it really becomes a vicious cycle. If you have somebody that's malnourished and they get diarrhea and they're fevered, that worsens the malnourishment and so on. So it becomes a cycle. Now, all of these data doesn't include something important that has recently been discovered, and that is that measles actually causes immunosuppression. So if a child gets measles, it decreases the ability of that child to fight off other infections. Now, we knew that before, but we thought it sort of lasts like a month to 2 months or so. But recently it has been demonstrated that this actually can last 2 to 3 years after measles infection, which makes the child susceptible to other infections for 2 to 3 years. And so the thought is that measles-related deaths are being underestimated because we don't really know what the impact is of this immune suppression thing. It's not really been that well studied. We just recently discovered that it lasts that long. So that, for me, is a pretty serious thing to keep into account. The bottom line of this is measles is very infectious and it's very dangerous. The next point we have to make is that measles vaccination is effective, safe, and cost-effective. So 1 dose of measles-containing vaccine is 95% effective in preventing measles. So if you inoculate a child with measles vaccine, 95% of children develop an immune response and become immune. If you do 2 doses, then more than 99% become immune. The data from the US and from other countries show dramatic decreases in measles cases since vaccines have been introduced. And in fact, if you vaccinate into high enough numbers, you can eliminate measles from a society. And we'll talk more about that in a little bit. Measles vaccine has some adverse effects, but most of those are things like rashes or joint pain or fever or things that pass really quickly. serious adverse effects are very rare. So there's only really 3 that I count as serious adverse effects. So febrile seizures I count as sort of a moderate adverse effect, but since febrile seizures have long-term good outcomes, I don't count that as a serious adverse effect, especially if you consider that measles as well causes seizures, and probably in slightly higher frequency than the vaccine. So that cancels each other out. But if we look at serious adverse effects that I consider serious, the one is it can lower your platelets for a few weeks. And this happens in less than 1 in 30,000 cases. Now that almost never causes a serious bleed, but I count it under the serious adverse effects. It usually passes without any trouble. The second serious adverse effect is serious allergic reaction. That happens in less than 1 in a million cases. Because the risk for allergy does exist, that is also contraindication. Children who are allergic to the vaccine or to vaccine components should probably not be vaccinated. But still, it doesn't occur that frequently, less than 1 in a million. And the third one, this is encephalitis. Now, there's been some case reports that you can get brain inflammation sort of related in time to measles vaccination. There's not been enough to establish a statistically significant link through studies and evidence. But if we assume that the case reports are accurate, then it happens in less than 0.22 per 1 million cases. Now that is so extremely rare. And in addition to that, the brain inflammation that is described as being associated with the measles vaccine doesn't even come close to the kind of thing that you get from measles. So to put that into perspective. Now you might say to me, well, 1 in 30,000 cases of low platelets, less than 1 in a million of serious adverse effects, less than 0.22 per 1 million of brain inflammation. How does that compare with other risks that children take? Well, consider this one. We regularly give children ibuprofen for fever treatment. And studies show that ibuprofen is associated in children with a risk of a gastrointestinal bleed that requires hospitalization in about 1.7 per 10,000. So, 1.7 per 10,000 children will get a serious bleed from ibuprofen. That is magnitudes higher than any of the adverse effects I've just said, yet we frequently consider ibuprofen as treatment for fever and we think that it is safe. Or consider car accidents. In 2013, the risk of dying in a car accident, if you are in a car, is 1 in 47,000. Now, that we wouldn't even consider as a risk when we put our children in the car. But when you compare that with measles vaccine has 1 in 30,000 cases for low platelets, less than 1 in a million for serious allergy, less than 0.22 for 1 million for a less than serious brain inflammation. And you can see that the risk is what we would consider acceptable when looking at other everyday risks that children are exposed to. So the bottom line is that measles vaccine is effective in preventing measles. It is safe in that the adverse effects are really not, the serious adverse effects really don't occur that often, and it's cost effective. A next point that we have to make is that measles can be eliminated from a society, and that there's a concept that we can call herd immunity. Now, what herd immunity is if enough people in society are vaccinated against the disease, then the chance that people who are not vaccinated or who remain susceptible to the disease get in contact with measles is very low, so they are protected. But now the trick with measles is because it is so very infectious, you need a very high vaccination rate to make sure that those who are not vaccinated are protected. And really, what you need is 93 to 95% coverage with 2 doses of measles vaccine. So that's why places like the CDC or the WHO, they all recommend these kinds of rates of coverage with measles vaccine, 93 to 95% with 2 doses. Societies that fall below that will over time accumulate enough susceptible people in their population to sustain outbreaks. Now, even if you eliminate measles from a society, if you keep up this high coverage, then over time, measles won't occur in your society, and elimination from your society will be sustained. You can still import measles cases. So people travel to your society and they have measles, and so now if by chance they come into contact with some of the people in your society who are not vaccinated, you can get outbreaks. So we call this imported outbreaks. Another funny thing that we see, and this has been well described, is that people who refuse vaccines or for some reason are not vaccinated and remain susceptible, they cluster geographically. So if you have a map, you can sort of draw little pockets in the population where people are susceptible to measles and where outbreaks can occur. So imported outbreaks tend to occur in these pockets and spread among susceptible chains. So even though we talk about herd immunity and we talk about elimination, realize that we need a very high coverage with 2 doses, and there still are usually pockets of susceptible people within the population. So that's the last point I want to make. There's always a susceptible group. Now, if you think about measles vaccine, we give it at, say, 12 months of age, the first dose, the second dose at 18 months or at school age. Now, there's a 5% failure rate with 1 dose. So I said it's 95% effective. With the second dose, it's more than 99% effective. So in between those first and second dose, 5% of those kids are still susceptible to measles. Before 12 months, most of those kids are susceptible to measles because the parental antibody sort of runs out between 2, 3, 4 months, that sort of age. So between 2, 3, 4 months to 12 months, those kids are all susceptible. And to make it worse, over time, about 5% of people lose their immunity after vaccination. That's called secondary failure. And then, of course, there's those who are allergic to the vaccine, those who are immune compromised. So if you add it up, you'll see that there's always a group in society that cannot be protected through measles. Either they have a vaccine failure, which doesn't happen often, but it happens, or they're too young to get the vaccine, or they have some contraindication to the vaccine. So this ranges from population to population, but you can sort of assume, given those numbers, around 5% in your population is usually susceptible despite high vaccination rates. Now, those people depend on herd immunity not to get measles. If they get into contact with measles, they're going to get measles. Now, let's think a little bit about children. And there's sort of 2 ethical principles that have been suggested or that are used to make decisions for children. The first is what we call the best interest standard. Now, the best interest standard asks us to look at the available options and choose the one that is best for the child. Now, we have to look at all the child's relevant interests. We can't just pick and choose an important interest. The other principle that has been suggested is the harm principle, and that is sort of one of the new ways of thinking about how do we overrule parents, or when should we overrule parents. And basically the idea is that if parents make a decision that is harmful to the child, the state should overrule that decision and protect the child against harm. That sets the bar quite a lot lower than using a best interest standard. Most people use both. Most people say, okay, we are guided by the best interest standard. We should choose what is best for children. But if we really disagree with the parents, then the bottom should be the harm principle. We should really not be doing things that harm children. And so usually, measles vaccination, as I've told you, provides lifelong protection, has negligible risk of harm. Measles is a devastating illness. So it follows that measles vaccination is best for the child. And so the best interest standard would guide us to do measles vaccination for children who don't have an allergy and are not immune compromised. But now remember argument A, where some people say, well, not so fast. In a highly vaccinated society, maybe it's better for the child to rely on herd immunity instead. So if you read about the usual responses to this kind of argument, people have thought about this in the literature, you usually get two kinds of responses. The one response is essentially to agree and to say, well, we still think it's better for the child to be vaccinated, but the risk of harm is so low to the child in a highly vaccinated society that we really can't override parents. So essentially, we should just leave it alone. If parents don't want to vaccinate and herd immunity is in place, we can ask the parents to reconsider, but essentially we should leave them alone. But a second response then is to say we should realize this is unfair. Now, this is the idea of free riding. So free riding, I've got a picture over there of a public transport pay area. There's nobody there right now, so obviously it's not frequently used. But how free riding works is a public good is established by everybody doing their bit. So public transport is established by everybody paying their fees. Now, if you use public transport without paying your fee, you are free riding, and that's unfair. You're not contributing your bit. So the argument is, if you rely on herd immunity, but you won't contribute to herd immunity, that's unfair. So you're acting unjustly. And that's usually the response to parents who reason this way. But you're thinking in a way that is unfair. You're acting in a way that's unfair. You're not contributing your fair share. But I want to go even deeper than that. I'm going to examine this argument and show you that measles vaccination is undoubtedly better. And I'm also going to show you that argument A, this argument that says it's better for a child to be unvaccinated, defeats itself and is logically not sustainable. And both of those show us, I'll show you that it means that we really should be vaccinating our children even in a highly vaccinated society. And that has implications for how we talk with parents and how we think about vaccination policy. So again, just to remind you, this is the argument that we're talking about. The risk of measles is low, so measles vaccination has risks. We should do what's best for the child, so we shouldn't vaccinate because that way we avoid vaccine risks, but we protect our child. But if you think about it, we can change that number 1 and number 2 to the following. Herd immunity reliably protects a child from measles. Let me just go back and show you. So, the benefit from measles vaccination is low in a highly vaccinated society because the risk for getting measles is low. That's the same as saying herd immunity reliably protects a child from measles. And then the argument stays the same. Now I'm going to challenge that thing. I'm going to challenge the idea that herd immunity is as reliable as measles vaccination. So here are some reasons why vaccination is better. First point I'd like to make is that vaccination, the figures show, is a better and more reliable protection. Now I've got a picture down here of a sort of a porous membrane where stuff can get through. That is what herd immunity is like. Next to that I've got this citrus fruit, which I don't know what it is, but it's got a very thick skin. So you can't get easily to the center there. That's more what measles vaccination is like. So I want you to keep that in mind as I go through some of the facts here. So even in highly vaccinated societies like the USA, Canada, and the Netherlands, where measles has been eliminated, we often see measles outbreaks through imported cases. And this is really because of what I told you before. There are always susceptible people, and for some reason they tend to congregate. So in the Netherlands, for example, the measles vaccination rate is over 96%. But they've now for over a year had a sustained outbreak in a community, in a religious community in what they call their Bible Belt. It's the name of a geographic region there. And the people who live there are known for, one of their tenets of their faith is that they will not accept vaccinations. So we have very low vaccination rates just in that area. And so for over a year now, they've had a sustained serious measles outbreak despite having overall population vaccination rates of 96%. And we see the same here in the U.S. We all remember the Disneyland outbreak where some kid had measles at Disneyland, and other people who were susceptible got in touch with that. And the outbreak spread through susceptible chains all the way to Mexico, to numerous states, to Canada. It became a big outbreak affecting many countries. And that is because we get within these highly vaccinated societies chains of susceptibility that congregate together. Now, you as a parent don't know whether you live in a highly susceptible area or not. In fact, it's impossible for most of us to predict that. It depends on local vaccination rates, people moving in and out, people, giving birth, people, you traveling, people coming to your school where your kid goes to, people walking by you in the store, people on vacation. So through a variety of unpredictable local factors, the susceptibility of the community around you changes. It's a dynamic thing. So herd immunity is not this solid, immovable thing. It's a dynamic thing that can be affected by a variety of local factors. So if you rely on herd immunity for your child, it's no better than gambling. You're gambling that, well, the people around me are sort of vaccinated enough to protect me against imported outbreaks. And to me, that does not seem consistent with the ethical principles governing decision-making for children. So that's the first point. Vaccination is obviously better than herd immunity. The second point is that actions of others can compromise herd immunity. So we're making an assumption that once measles is eliminated, it will always stay eliminated. Once vaccination rates are high, it will always stay high. But that's not true. That depends on the vaccination behaviors of other people. You don't know that other people are going to vaccinate their children. You don't know that vaccination rates are going to stay high. In fact, in the United Kingdom, this is exactly what happened. They had eliminated measles, and in 2006, measles became endemic again. It became just, a sustained illness that's around again because of declining vaccination rates. Now, they had some reasons for that. There was that whole vaccination autism scare because of the study, the fake study that was published. But that was a good reminder for us what can happen. Suddenly, you have decreasing vaccination rates. Measles is now around again. And now your unvaccinated child is at risk. So that's the second point. You have no guarantee that vaccination rates are going to stay high. The third point is if you do the numbers, you'll see there's actually very little room for non-vaccination. We said you need about 93 to 95% vaccination with 2 doses to keep measles out, to sustain elimination. And we also said there's always a portion of society that cannot be vaccinated. So let's say that's about 4 or 5%, that are allergic or too young, or they lose their immunity through vaccine failures or whatever. Now you can see that that doesn't give you very much room for people to refuse vaccination. In other words, kids who can get vaccinated to not be vaccinated before you start adding susceptible people to your population and start losing the threshold that you need for sustained herd immunity and elimination. So really, we can't tolerate that many vaccine refusals before we get into trouble. A fourth point that sometimes escapes people is that if you get measles in a highly vaccinated society, your risk for complications are worse. Now, there's been research done on this, and sure, your risk for getting measles is lower because, the herd protective effect. But if you get measles, your risk for complications are 4.5 times higher than the numbers that I previously cited. So if you happen to be living in one of these areas where there's lots of susceptible people around, or if we happen to have too many refusals or missed opportunities so that we lose the vaccination threshold and we get a measles outbreak, those that suffer from measles in that outbreak have a higher risk of complications than has been historically shown. And the last one that I want to say as to why vaccination is better is that non-vaccination limits a child's options and freedom, and in other words, impinges on a whole lot of childhood interests that sometimes we forget about and that we shouldn't forget about. Now think about this. In contemporary society, we travel a lot. You travel great distances to go to school, to work, to church or worship or whatever, leisure, vacations. And that is just how society is. We are a mobile society. Now, where transmission happens of measles for susceptible people is precisely at these places we travel to. It's at the doctor's office, at school, places of leisure, places of worship, at work, even emergency rooms. So really, for an unvaccinated child to be fully protected against measles, you really have to avoid all those places. You have to avoid going to the doctor's office without calling ahead and making sure that there's no measles cases around. Or you have to avoid going to school. You have to avoid, you have to make so many choices that limits the child's participation in society if you want to avoid measles, that it places burdens on the child that goes just far beyond the burdens that we've described of measles vaccination. So the argument that I would make here is that to choose for non-vaccination and to then want to avoid measles places burdens on childhood interests that is just, not acceptable. But even if those do not convince you, which I think they should, there's a second important point, and that is that this argument is self-defeating. So that means that if we actually did what the argument said, we would not get the conclusion that the argument reaches. The argument defeats itself. So how this works is, let's imagine a child. This child is in a highly vaccinated society. We have to decide whether we are going to vaccinate the child. And we use this argument. We say, no, we shouldn't vaccinate the child. So we don't vaccinate the child. Now in comes the next child, and we should decide whether we're going to vaccinate this child. And we say again, no, this argument says it's better for the child not to be vaccinated, and so on and so on. And so we go on, and then suddenly one day we find now we have all these unvaccinated children, and we don't meet our herd immunity threshold, and suddenly our society is susceptible. And these children that we've not vaccinated are now at risk of measles. We haven't protected them against measles. So if we try and follow this argument's conclusion, which says we shouldn't vaccinate children because they're safe against measles, we make them unsafe against measles, and we make it guaranteed that they one day will be susceptible to measles. So it defeats itself. Now, it's not obvious, you could say, well, day to day, we could just stop there where we see, okay, if we do not vaccinate this child, then we're going to lose herd immunity. But it doesn't work quite like that. It's not that obvious in day-to-day vaccination which child it is that tips us over the edge. And it's actually all the children that tip us over the edge, not just this one. So what I mean is that if people use this argument and forego vaccination and rely on herd immunity, it will inevitably lead to a dramatic fall in vaccination rates, and eventually we will lose herd immunity. So the goal of protecting the child by relying on herd immunity cannot be reached by appealing to this argument. And this isn't just a theoretical point. Again, I will refer you to the United Kingdom, where this very thing happened. Those children who were protected, quote unquote, through non-vaccination, all were exposed to measles because of the reestablishment of measles transmission. Now there's two ways that you can sort of think about this kind of argument. The one is to say that it is not universalizable. So if we try and make it a universal rule, it fails. And that shows us, we can't really use this for our children. The other way to think about this is the tragedy of the commons. So I have a picture here of sheep grazing. Now you see where the sheep are grazing, there's no grass, but way over there, there's a lot of grass there by the hills. So how the tragedy of the commons works is imagine a society with lots of cattle, and they want to graze their cattle on the land. Now, for the individual farmer, it works out better if he has more cattle on the land. So he puts more cattle on the land. Now, every farmer thinks that way, so they all put a lot of cattle on the land. But now what happens is that the cattle overgraze the land, and so then you get what you see here. There's no grass. It sort of destroys the grazing. And then eventually it destroys all the cattle, and the whole town loses all their cattle. However, if they all work together and they all limit the amount of cattle they put on there, they can sustain the resource and they all benefit. It's that kind of argument. So if you say, well, it's better for me to not be vaccinated, you should realize everybody will think that way, and then we will lose herd immunity, and then you will not be protected. So really, it's not logically sustainable to use this argument that way. So the conclusion then that I reach is that vaccination provides reliable protection. Herd immunity is not reliable protection. However, some people, who can't get the vaccine depend on it. That's the best they can do. But we should realize that vaccination is really better. And that, lastly, this argument is self-defeating. So I conclude that measles vaccination is obviously best for a child unless there's medical contraindications. And from there, I conclude that those who stand in relationships with children, that's parents, clinicians, governments, they have obligations to vaccinate eligible children. Now, there's two reasons for this. The one is the public benefit, or remember the free riding argument I mentioned? We all have an obligation to pay our fair share when we use a public good, that kind of thing. So using the idea of the public benefit and our obligation to sustain the public benefit is one leg of the justification for these obligations. But the other is the best interest of the child. There is no way, having thought through this argument, that you can say it is in the best interest of a child to forego vaccination. It is undoubtedly best for the child to be protected against measles. And so these support these obligations. So let me just mention two more things. One is policy suggestions, and then the other is tips for speaking to parents. Now, I think we should use a wide variety of policy suggestions. We oftentimes get caught up in just one of these. So the first thing that I would say we should do is we should have some sort of mandatory policy, and it should be an opt-out policy where we make it hard to say no. In other words, I think there's good data and good justification for saying that there should be mandated vaccination. States in the US that have mandated vaccinations have much higher rates of vaccination than states without. And we can see from studies of opt-in or opt-out policies, if we ask people to opt in, well, the rates of vaccination go down. If we ask them to opt out, which means we're going to vaccinate your child unless you tell us no, then vaccination rates go up. If we make the opt-out harder, in other words, we say you have to come in and listen to an education session, you have to sign forms, you have to explain to us why you opt out, the harder we make it, the less people opt out. So the advantage of having a strongly worded opt-out policy or making it hard to say no is we know that that increases vaccination rates while still providing an opt-out for people who really, have strong convictions about this. I think that is the best way to go to balance different ethical goals. The second point is that education should be used, and that should be used in person, in clinics, but also publicly. Just want to caution you that education should be well researched. Some studies have shown that education can backfire if you do it incorrectly. people who have very strong anti-vaccine views, if you share studies with them or research data with them, because of psychological reasons, you increase their resistance to vaccination. So they hear what you're saying, they just become more sort of staunch in their anti-vaccine view. And so really, if we do education, we should, on the public scale, we should really research the things that we are putting out before we put them out. But for me, the main point that complements these two is that third point there, the idea of trusting clinical relationships. Research has shown that something that protects parents against anti-vaccine messaging is a trusting clinical relationship with a primary caregiver, whether that be a primary care nurse, a pediatrician, a family physician, some sort of primary caregiver that is a source of trusted information. Because such parents can sort of think about what this trusted person tells them and resist the anti-vaccine messaging. Parents who have such trusting relationships with clinicians are much more likely to vaccinate, much more happy with their understanding of vaccines, get much better information. So for me, the basis of our vaccine strategy and indeed of all our care to parents is that we should encourage trusting clinical relationships. So I think any public policy should have these three legs and should stand on all three of these legs. Now, let's just talk a little bit about talking with parents. I already mentioned with you we should foster trusting relationships. So I assume that most of our talking is going to be done against that background. Now, when you talk with parents, it's important that you frame your discussion in terms of your shared goal, which is the health of the child. In other words, you're on the same team. You see the pictures here, the hands are people working together. They're all interlinked. Versus adversarial, us versus them. That's now the boxing glove person there. So too often in clinical medicine, we get the boxing glove thing going on where it's me versus you and my opinion versus your opinion, instead of removing ourselves from an adversarial situation and placing us on the side of the child, saying that I'm an advocate for the child. And so I would encourage you to frame your discussions against that backdrop. Your concern for the child, you're wanting to do what is best for the child, saying that we have this shared goal of making sure that the child's health needs are met. And I have done this in practice, and it's not a magic sort of charm, you know, but it does get you a lot further than the adversarial thing goes. When you become adversarial, me versus you, that parent is not listening to you any further. You should really try and create that trusting environment and leveraging that trusting environment. And that takes time. I remember speaking to a parent for numerous different visits where she went from absolutely no vaccinations to, well, I'm a little bit worried about measles, to, well, now I feel I'm between a rock and a hard place because measles is so dangerous, but the vaccines are also so dangerous, to at least considering, okay, maybe we will do some vaccinations. And I mean, that was 6 months worth of work. Now, of course, that delays vaccination. That is a different conversation for me. What I just don't think works is ramming studies down people's throats where there is no trusting relationship. The key here is to use the language of shared goals and being on the same team. The second point I'm going to use some research done by Doug Opel and his colleagues at the University of Washington. So what they did was they recorded a whole lot of vaccine conversations and compared the language used by clinicians to see what was the eventual outcomes. It's a really good piece of research. And I've given you the reference there at the bottom. What they found is how we phrase our conversation is important, and specifically how we initiate the conversation. So there's two ways we can do it. You can do some sort of participatory thing, something like, so what do you want to do about shots? So what do you want to do about vaccinations? Or how do you feel about vaccinations? Or you can use what they call presumptive language, saying something like, okay, so today is the day for shots, or, today measles vaccines are due, or something like that. Now, they found that there's significantly higher odds of resisting vaccines if you use a participatory thing. Nothing else is different between the clinical scenarios except just the language used. They find that the odds are 17.5 times higher of refusing vaccines if you start off with saying, well, how do you feel about vaccines? That should maybe not come as a surprise, given the absolute bombardment of conflicting messages that parents face. What's strange, though, is how well parents respond to a confident, well, today is the day for vaccination kind of language. They further saw that if parents resist and the clinicians stick to their recommendation, then eventually 47% of those parents change their minds. Now, this was only in short follow-up, like within that same visit. This doesn't even start to tell you what happens downstream. Like I told you, some parents you have to really walk the long walk with before they start hearing what you're saying. We should realize that parents who refuse vaccines fall either in the camp of being really uncertain but wanting what is best for their child and need reassurance, or fall in the camp of having alternate beliefs about health and thinking that chemicals are bad and that kind of stuff. We really, the remedy there really is to leverage your trusting relationship. But the second point is thinking about how we talk and using sort of more, well, today is the day for vaccine language is important. And there's also value to sticking to our recommendation and not just caving. So that's what I said to you. Use the presumptive initiation. I think it's the obligation of clinicians to take the lead in this conversation. You know that many children who are not vaccinated are because of missed opportunities in practice. Not just because of vaccine refusal, but sometimes we miss the opportunity in practice because we're busy. We have all these other things you have to weigh and measure and, do millions of other stuff. So it's our obligation as clinicians to initiate the conversation. I also think there's evidence for communicating your recommendation and staying with it. And remember the value of the trusting relationship. I just want to remind you of my conclusion here, that vaccination is reliable protection. Herd immunity, some have to depend on it because they have no choice. But if you don't have to, it's not reliable protection. And lastly, this argument was self-defeating. And so measles vaccination is best for the child unless you have medical contraindications. And so I think parents, clinicians, and governments are obligated to vaccinate eligible children. And this is justified by the best interests of the child and by public benefit. And that is what I have for you today. I'm not seeing any questions, but I would be happy to entertain any questions.